Thank you to the NATF and the organizers for the invitation today. These are my disclosures. So the goal of our talk this evening is to review how RV physiology informs the approach to the care of the acutely decompensated pulmonary hypertension patient. We're going to focus on a couple of themes. We'll talk about a case report of acute on chronic RV failure in a predisposed patient with chronic thromboembolic pulmonary hypertension. And what we were tasked with was to try to tie this discussion back to some of the themes that we all reviewed in the 2023 Right Heart Symposium, specifically here relating how RV coronary perfusion and heart-lung interactions inform a structured approach to RV resuscitation. And then we're going to emphasize areas of clinical practice where further scientific guidance are needed. So we begin with a case. We have a 43-year-old man with antiphospholipid antibody syndrome complicated by chronic thromboembolic pulmonary hypertension, recurrent embolic DVT-PE, at some point, actually over 20 years ago now, had a non-retrievable IVC filter placed that has subsequently thrombosed and is felt to have chronic IVC occlusion, but also the likelihood of intermittent recurrent embolic events emanating from that thrombosed IVC. The patient has been treated surgically with a pulmonary thromboendarterectomy and also had PFO closure at that time. And that was 6 years prior to the current presentation. Has had multiple sessions of balloon pulmonary angioplasty for residual precapillary pulmonary hypertension, and was ultimately managed at that point due to impaired functional status, and him being still a young man, was treated aggressively with ambrisentan, tadalafil, and IV treprostinil to manage the residual pulmonary vasculopathy on top of his background anticoagulation. He was reevaluated in multidisciplinary fashion given poor functional status, and he was judged to have no further anatomic targets left for either surgical or interventional procedures in the pulmonary vasculature to address the chronic thromboembolic component. But given the question of ongoing embolic events and given the patient's age and anticipated clinical course, it was ultimately recommended that the IVC filter be removed to try to minimize foreign bodies that could precipitate further thromboembolic events. Pre-procedure, he had a hemodynamic assessment that was notable for a mean PA pressure of 35, a preserved cardiac output. The index was that's a typo with the index there, but modest pulmonary vascular resistance. But overall, hemodynamics were well treated leading up to the procedure. So our story begins this evening when we were stat paged to the interventional radiology suite by the anesthesia team, who were intending to start the patient on milrinone for acute hemodynamic decompensation. And actually, the fellow that was on with me is actually here tonight, so he can call me out on any exaggerations or any creative license that I took with the case. When we got there, we had to, put on the bunny suits and go into the procedural area, and we learned that the case began as a monitored anesthesia care sedation, but removing this 20-year-old non-retrievable IVC filter was understandably very technically demanding, and the patient subsequently developed hypotension and worsening hypoxemia. He underwent conversion to general anesthesia, and that, of course, led to further hemodynamic deterioration. We were told that the end-tidal CO2 was normal throughout the case. The ABG obtained after the onset of hypotension was notable for a mixed respiratory and metabolic acidosis. And there was some discussion whether the patient could have sustained a new embolic event in the setting of all this procedural manipulation. But our colleagues in interventional radiology appropriately did a stat pulmonary artery angiogram, and we were at least able to rule out any acute large central obstructive clot. The filter prior to our arrival had been eventually removed, and there was significant blood loss associated with the procedure, estimated about 200 cc's. But unfortunately, they were able to restore the patency of the IVC. We saw intraprocedural labs notable for mild bicarb, mildly low bicarb, but a normal lactate and a little bit of acute kidney injury. At this point, the patient was requiring high doses of vasoactive support, including epi at 10, vaso at 0.08, and was intermittently getting pushes with both when he was becoming acutely hypotensive. So at this point, we did a couple of things. We made sure the CAD pump that the patient was receiving their treprostinil on was infusing. The anesthesia team had started inhaled epoprostenol on top of this background therapy. And we had to start making management decisions. So the first thing we opted to do in real time was to put a probe on the chest to try to get a sense of what could be contributing to the patient's hypotension. A lot of different factors, not all necessarily cardiogenic. This was in reality an echo that was done about 45 minutes later on ICU arrival, but it looked very similar. Depicted here in the subcostal view on our interpretation was moderate RV dilation, but actually maybe only moderately depressed RV systolic function. It didn't look as bad as it could potentially look. Granted, this was on very high doses of vasoactive support. The short axis view was notable for a modest degree of interventricular septal flattening, but generally preserved filling of the left ventricle. When I heard the story, we scooted down there. I was expecting to see a gigantic right heart, an empty left heart, and a patient, essentially on the verge of needing mechanical support. However, our assessment was that the acute RV failure was potentially salvageable with medical management. One of our suspicions that there could be a component of superimposed distributive physiology rather than just a strictly primary cardiogenic source of the decompensation. So the clinical questions for our following discussion are as follows. Number one, what was the precipitant of the hemodynamic collapse? And as we'll see, I think the structured approach to RV resuscitation in real time, there's a lot of things you need to do to get the patient better and temporize, but ultimately you need to search for the underlying precipitant of the problem to have the best chance at reversing it in timely fashion. What vasoactive strategy would we use to support RV function? Is this a inotrope? Is this a vasopressor? Is it both? And this ties into the discussion that we had back in November of last year, when Dr. Dubrak and I respectively spoke about the role of vasopressors, the role of inotropes, and then balanced agents. And how do we go about choosing these, given the fact that there are no high-quality randomized controlled data to inform the use in this setting? And then what other supportive measures are needed? Because we all understand now that it's actually almost the wrong answer to be perseverating on what agent to use. You have to do a lot of things in parallel, and only one of which involves the use of a medication to modulate systemic vascular resistance. So to answer these questions, we'll review the pathophysiology of coronary blood flow to the right ventricle. We know that the RV, compared to the LV, it's really highly dependent on RV perfusion pressure to maintain right coronary artery blood flow. Compared to the left coronary artery, the RCA lacks the ability to auto-regulate flow when coronary perfusion pressure drops. In right heart failure, therefore, the right heart is much more vulnerable to changes in perfusion pressure. So what does this mean practically? We can see depicted here in this plot of coronary blood flow versus coronary perfusion pressure. In the setting of the right heart, we can kind of approximate coronary perfusion pressure as the difference between our MAP and then some sort of mean RV pressure. I think practically a lot of people think about RV EDP. A lot of the research studies will use something like a mean right heart pressure, accounting for both systolic and diastolic contributions. But we can see that when you drop coronary perfusion pressure, the left coronary artery can defend blood flow through a variety of autoregulatory mechanisms. However, in the right coronary artery, which is supplying the right ventricle, essentially a drop in perfusion pressure leads to, by necessity, a drop in coronary blood flow, therefore can set the stage to develop RV ischemia and worsening systolic function. So we also know that in health, the right coronary artery perfuses the right heart in systole and diastole. By contrast, we know this changes in pulmonary hypertension. So in PAH and in CTEPH, we know that this has important consequences. So depicted here is a plot by the von Nordgraf group, where we see as RVSP rises, the systolic contribution to coronary blood flow falls, making the right heart more reliant on diastole for perfusion. And in right heart failure, this means that factors influencing diastole, such as arrhythmia, high filling pressures, and so forth, can further predispose to impaired coronary blood flow and ischemia. And then we can see this, what does this mean functionally? And we can see data for that in the next figure. So in 23 patients without epicardial coronary artery disease undergoing myocardial perfusion imaging, along with echo and right heart cath, we can see that the patients with evidence of RV ischemia have much higher filling pressures and lower MVO2s than those patients without evidence of ischemia. So we can see that RV perfusion matters. And in the context of right heart resuscitation, we have to think about these, specifically the effect of the choice of our vasoactive drugs on mean arterial pressure, given the implications for coronary perfusion. So we're familiar with the RV failure spiral, where in a predisposed host, acute insults such as hypotension, hypoxemia, arrhythmia, positive pressure ventilation can lead to hemodynamic decompensation from right heart failure, which can in turn beget further hypotension, RV ischemia, and descent into circulatory collapse, as we were starting to see in this patient. So we understand that loss of coronary perfusion pressure now promotes myocardial ischemia, and that can translate into functional problems with the RV in the form of reduced systolic function, but also increased filling pressures. So we know mean arterial pressure is an important determinant of coronary perfusion pressure, and it's proportional to systemic vascular resistance as well as cardiac output. However, in the setting of acute RV failure, such as a patient with advanced PAH, advanced CTEPH, it may not actually be possible to reliably increase cardiac output all that much. So in an acute situation, sometimes the only thing keeping that patient alive is your systemic vascular resistance. So in that context, maintenance of MAP is critical because it's essentially keeping the RCA blood flow sufficient to maintain RV function. So we have essentially seen in the right heart, we're also thinking about not only SVR, but optimizing filling pressures on the right side of the heart. So in this setting, choosing medications that increase or preserve SVR, but also ideally decrease pulmonary vascular resistance would be advantageous. So how do we translate this practically? So there's a variety of drugs out there for RV support, and we can roughly divide them into categories of vasopressors and inotropes. And again, this is touching on the themes that Dr. Dubrack and I discussed in the prior Right Heart Symposium. So we know that our pressors increase systemic vascular resistance. They have some effect on contractility depending on the agent, variable effect on cardiac output. We know what they are. For the purposes of this conversation, we're thinking about norepinephrine, phenylephrine, vasopressin, epi, dopamine theoretically, but I think most practice patterns have moved away from the use of that, especially in the pulmonary hypertension patient populations. And, one concern that comes up is, alpha adrenergic agonists and their effect on pulmonary vascular resistance. So, on rounds, we hear about this a lot. We'll go down the line, you'll ask the intern, the resident, well, what drug should we use in pulmonary hypertension? Well, it'd be really good to, vasopressin is really the first line drug and so forth. But then you go to the fellow, then you go to the attending, and they say, well, actually, it's whatever you can get from the code cart in time to keep this patient from coding. Because in reality, hypotension is a far bigger threat. Chances are you don't have a central line. And, vasopressin, if you have it, great and in line, it's a cute answer, but it's not always necessarily something that is practically accessible in the heat of the moment. So, and we reviewed some data in our prior conversation last November, how although there's data that vasopressin might improve pulmonary vascular resistance, there's nothing that necessarily points to improved clinical outcomes in select patient populations, such as those with right heart failure post-cardiopulmonary bypass. Inotropes, on the other hand, they increase our contractility. They usually decrease our systemic vascular resistance, but in some patients, they will increase cardiac output. And specifically for the purposes of our talk today, we'll be talking about dobutamine, milrinone. As you remember, that's how this began. We got a call that said, we're about to start milrinone. Can you come down? So the problem is that these agents in real time usually often make folks hypotensive before you start to realize the benefits of increased cardiac output. They certainly have their choice, though, and we'll propose an algorithm for how we can think about that in the following slide. Then ultimately, there's a couple of drugs that are very clinically accessible that do a little bit of both, that give you a nice opportunity to hedge your bets in real time. And, and that's what that's, as an intensivist, it's usually my inclination to reach for one of these. It's often one of the ones that I have in hand, pre-mixed, ready to go for a patient. So in the absence of high quality evidence to guide our practice, this is a paradigm that I propose and that we can debate about that I think is a reasonable approach for a practical use of vasopressors versus inotropes for right heart failure. And this is what we talked about during the Right Heart Symposium. So for our patients with pump problems, this is impaired contractility in the setting of a normal RV afterload. These are patients with post-cardiopulmonary bypass, with post-LVAD RV failure, RV cardiomyopathies like ARVC, RV infarcts. The goal here is you want to preserve contractility, maintain the SVR. And in this situation, it's very reasonable, because there's a contractility problem, to reach for an agent that augments contractility. In addition, you need to think about optimizing RV preload, optimizing heart rhythm, maintenance of a suitable MAP, and providing meticulous supportive care. However, as a pulmonologist, I spend most of my time in the world of RV afterload problems. And you have to think about this in a different way. And this, even in the hospital, you'll see people conflate these two different syndromes of RV failure, and they're not the same. So for our patients with obstruction to PA blood flow, these are our patients like the patient in the case, chronic thromboembolic pulmonary hypertension, PAH, PH-ILD, even pulmonary embolism to some degree. We can also think about, in a similar light, people with mechanical obstructions to blood flow somewhere between the right heart and the left atrium, people with stenotic pulmonic and aortic valves. And I love this quote from Dr. McLaughlin, and I teach this to all of my residents, that when we're thinking about PAH, we can think of it almost as a fixed obstructive cardiopulmonary lesion in real time, because we know it's going to take a while for the pulmonary vasodilators to work in the ICU. And even in the ICU, they're only going to work so much. And really, pulmonary vasodilators, as we all know here, it's a game of months rather than minutes. So in these patients, our goal is to decrease the obstruction and maintain or increase the SVR. So, for patients such as this, I'd propose a vasopressor first strategy. And in addition, for those patients, who don't have PAH or CTEPH, patients with PE, you obviously want to address the PE. Patients with a pulmonic valve problem, aortic valve problem, that's obviously the thing that you need to be focusing on fixing. And then finally, the world of our cardiology colleagues is post-capillary pulmonary hypertension. And in this particular situation, the goal here is treat the post-capillary process. Get the wedge down. If it's a valve problem, fix the valve. And that's another great patient population for inodilators. So what did we do in this particular case? So one of our suspicions was the patient was hypoventilating throughout the case, given that the blood gas showing hypercapnic respiratory failure with a small metabolic component. A teaching point that we thought about was that they were following end titles for most of the case. And in a patient with high dead space with pulmonary vascular disease, your end tidal CO2 is not going to equal your PA CO2. We suspect that the positive pressure ventilation exacerbated the hypotension. But ultimately, one would need positive pressure when you get to a point to address the gas exchange problem. We supported coronary blood flow initially with a strategy that was started in the IR suite of epi and vaso. And in the ICU, he was transitioned over to norepi and vaso. And we avoided inodilation here, given the concern that this guy was holding on based on his SVR. And if we started milrinone, especially in this patient in renal failure, he's going to get hypotensive and we could risk further compromising RV blood flow. He was anticoagulated. There was concern for embolic event up front. He was too unstable for a CTA, but we didn't see an empiric indication for thrombolysis. We continued the vasodilator regimen that we discussed, and ultimately underwent central line placement to quantify central venous pressure and central venous sat. And this is what happened. So he got to the ICU. A central line went in showing a CVP of 4 to 6 and a central venous O2 sat of 80%. So that was compatible with, actually a relatively compensated, arguably underfilled right heart. By the Fick principle, we're looking at a situation likely compatible with preserved cardiac output, or at least good enough cardiac output, and potentially a situation more compatible with distributive shock. So he had an infiltrate on his chest x-ray that blossomed, and he eventually ended up developing Moraxella and sputum in his Moraxella and MSSA growing from the sputum, concern for maybe an aspiration event leading to a pneumonia. Eventually had a CTA that was negative for PE. And after we got the information from the central line, the epi was transitioned over to norepinephrine, and he got a little bit of volume and blood product back and came off vasoactive support. And the patient was ultimately discharged home on post-op day 8. And this was actually his echocardiogram from the day before discharge. And you can see, the right heart is still mildly dilated, but there's been a marked improvement in RV systolic function. So what are the key points? So RV failure and management of RV failure really need to be individualized by the context and the patient. And I think sometimes in the hospital, we fall into the trap of thinking about right heart failure as the same syndrome, and people start thinking about the same things. Well, it's actually a lot of different clinical syndromes, and you really need to think about what's going on with the patient. As you can tell, I'm a big believer that SVR really defends RV perfusion, especially in situations when cardiac output can't be augmented. These are most of the patients I'm seeing. When their PVR is 10, there's only so much making that right heart squeeze harder is going to do. Conversely, the flip side of that is inodilators can hurt people sometimes, and they can lower your SVR, exacerbate hypotension. And in these patient populations, you have to at least think twice before initiating them. That being said, we don't have good quality data to guide us. And to resuscitate acute right heart failure, we have to hit multiple points in the RV failure spiral in parallel. And that the discussion of pressor choice and what single pressor or vasoactive altogether that you're going to use, it's a little bit of a trap. And it's actually a package of things that you have to do in parallel in real time. And sometimes it comes down to using balanced agents and things that you have on hand rather than the things that you'd ideally like to have on hand in a real world. And one of the things that we saw here was that in a patient with bad pulmonary vascular disease who has a lot of dead space, such as someone with CTEPH, end titles in an ICU or peri-procedural setting are going to be pretty unreliable, and sometimes you really need to get the blood gas. And then, I think it's important to emphasize that, there is no consensus on the optimal first-line vasoactive agent for right heart failure. And, balanced agents in the absence of those data, I think, are a reasonable and defensible choice. But I'm here to see if you feel otherwise, and we can have a conversation. So thank you.
Yep, thanks for that terrific case presentation. I would just add one comment, and that is that these are the patients, and I do know this case because I was involved with it, but these are the patients when they go for procedures, and there's always the possibility when there's an invasive procedure that they may need intubation. We always try to ask for cardiac anesthesia to be available because they know how to manage this as opposed to the code team that runs in and tries to intubate the patient and then just, uses different drugs.
Yeah.
So with that, are any questions for Dr. Weirtheim?
Great talk, Brad. Thanks for keying in on the SVR thing. That's what I teach the fellows all the time, is that's one of the major issues there. But in regards to that, the currently available agents outside of perhaps sotatercept lower SVR. Depending on the study you look at, about 30% as far as we know. So what's your practice in terms of when a patient comes in like this, in this state? Do you stop their orals? Do you stop their tray, put them on inhaled? What's your, I know there's no.
It's a good question. And
But,
I think
I'm looking for a sort of a consensus on what we should do there.
Yeah, no, it's a great question. And I think about it over different timescales. And I think in the situation where you're kind of called into the room, you're kind of pericardiac arrest, half-life of those agents are such that stopping most of those, you're not going to see the full effects of that for a while. So my order of operations is usually to get the support on board first, get the pressor started, get some of the other elements of the resuscitation underway. Think about making sure the ventilator's set right, and so forth. As you're moving into the ICU and things are settling down a little bit, I think there are situations where I have stopped the PDE5s. I think it's a risk-benefit analysis depending on how bad you think the PVR problem is contributing to the issue. If you have someone coming in, and this patient's PVR and all that, in all fairness, wasn't all that high, right? It was 3 to 4 Wood unit on therapy. So maybe stopping drug here would have been a reasonable thing to do. I think what helped, he turned around pretty quick. Within kind of 6 to 12 hours, we had him going in the right direction. If I was stuck with someone and then they were on 3 pressors and they're super vasodilated, their CVP's 4, and I know their PVR is pretty modest going into it, I might be inclined to stop some of the agents, at least in real time, but it's a tricky call. What do you do?
I mean, it's pretty similar. We do try to transition as much as we can to inhaled. I've had patients on inhaled milrinone, inhaled INO, inhaled epoprostenol if they're intubated. And then, I mean, that's usually I don't know. It's been our practice if they're on parenteral just to keep it going, at least for
Yeah.
the initial stage. But yeah.
Yeah.
What circumstances would you place a PA catheter in these patients?
It's a good question. And, admittedly, depending on which ICU the patient's in, that
point.
that
Yeah.
that has practice pattern associated with it. I think in this situation, at least for the first couple hours of someone's ICU care, if I can get a CVP and an essential venous sat, I can at least get a bead on what's going on. Is this more cardiogenic? Is this more distributive? And so I probably wouldn't be thinking about it unless I'm going down a road where we're in more cardiogenic than distributive, and I think I'm going to have to adjust vasodilators, but not in someone that isn't on their way to crashing towards ECMO. And you don't want to delay that to get a swan in. You don't need to make a decision necessarily on ECMO you don't need a swan to make a decision whether to go on ECMO. So.
Great. Thank you.
Question for you. So when you're reaching for these drugs, as we often do right off the code card, to prioritize increasing the MAP, how are you dealing with the tachycardia? Because that decreases coronary perfusion.
Absolutely. So I think it depends on, the epi to norepi decision point is one of those. And if you have a patient that's already in rapid AFib or has a history of recurrent AFib or as a history of other arrhythmias, they're in and out of SVT, I'm much more inclined to go for norepi. And I'm much more biased in general I think many pulmonologists are, norepi is like the bread and butter of the MICU, right? And you can take care of just about anyone with norepi, but it requires someone to mix it. They can mix it pretty quick, but when you're in a real jam, you can reach for the Coke cart and grab the stick and push 100 mics of epinephrine pretty quickly. So I would say in this particular patient, he was young, he had no arrhythmia history and so forth. The epi is reasonable while you're trying to sort things out. But I think it's what's been going on, that hospitalization and their arrhythmia protoplasm is the deciding factor for me.
Dr. Barber.
So just to push the envelope a little farther.
Yeah.
So this guy's a young guy. Okay, this guy just crashed and burned, basically. So how long would you wait, or how quickly would you consider ECMO in this guy?
It was the first question on my mind as we were on our way down there, and the initial plan was to get down there, try and get a sense of what was going on with the right heart. And maybe I was a little naive, but I actually thought that initial echo that I showed wasn't as bad as I was expecting. And so that kind of biased me a little bit away from it. We were prepared to go there pretty quickly, but between that and seeing that he was hypercapnic, I mean, that's something you can fix pretty quickly. He was already intubated, so it wasn't like we were going to have to intubate him again and make him risk destabilizing someone that, say, if you got that gas in a spontaneously breathing patient. So, things started, everything, like the time course of the resuscitation, he was better within an hour. So it was clear that we were on as soon as we started doing these things, he responded to each one. But I would say if he doesn't start responding, that's where he was headed. But yeah, so I actually called his outpatient PH doc as I was walking the quarter mile from the pulmonary division to the IR suite. And I said, you know this guy, what are you most worried about? And he said, I'm worried that IVC got opened up and he just got a big bolus of cardiac output that he hasn't seen in 20 years. And so that was one of the questions. But the interventionalist who was down there doing the case very quickly said that, look, I got the filter out, but I shot the IVC and it's still not patent. And, we don't see anything centrally. Pulled up the angio. We didn't see, anything large proximal as far as embolus. But that was, as I was walking there, that was the scenario that I was trying to figure out in my head. And if that was the case, it was going to be ECMO, because there's no way you're going to bring that heart back after that.
And the other thing is they had at least a substantial blood loss. So
Yeah,
they,
that's true.
right? So in some ways that may have helped.
Yeah. So
Yeah, well, thanks so much. That was a
Thank
really
you.
great case presentation.
it's good.
So